health equity has been an issue that has been around for a long time, but the COVID pandemic has really brought it to the forefront. And it is hard to talk about the last several years without talking about the COVID pandemic. And I think one thing that has become very clear with the pandemic is that health matters. Owen Arthur said, "For he who has health has hope, and he who has hope has everything." You know, and I think that really sums it up. I think that this is a conversation about health. So from a global perspective, you know, health was defined by the World Health Organization. They define health as a complete physical, mental, and social well-being, and not merely the absence of disease. And I think that definition is very important. You know, it's historically been criticized that it's really broad and that it's not a purely medical focus. But I do think that in the context of health equity, we do have to think about health in that broad perspective. The COVID pandemic really brought to the forefront all of the health disparities that have been in this society for a long time. In the United States, we saw that African Americans died at 2 times the rate of white Americans. And this wasn't just true for the United States, but globally what we saw was that those that were disadvantaged economically, physically, had difficulty, more difficulty. They died at a faster pace. They had illnesses. They sometimes didn't have money to deal with their illnesses. So this idea of health inequity really came to the forefront with the pandemic. Regardless of where you are in the world, healthcare economics is an important issue. And we all want to provide better quality of care, and we want to do it in a cost-efficient manner and really have better outcomes. And that really is the definition of healthcare transformation. So if you look at a pictorial where the patient is at the center, and we look at the different components of what it takes to really achieve this healthcare transformation, one of those components is really addressing health equity. And I think that around the world, we really haven't achieved healthcare transformation because we really haven't addressed adequately health equity.
The American College of Cardiology has realized that in order for us to improve cardiovascular outcomes and improve health care for everyone in our society, that we all need to embrace health equity as a goal. We need to be able to model what we're asking other people to do. And so our vision was, how do we achieve optimal health care for all, for everyone in our society? And we thought that we would do that and we would model ourselves appropriately by one, being sure that we work towards improving cardiovascular outcomes for everyone in the country, that we create a culture where cardiovascular health is our highest priority, that we embed health equity principles in everything that the American College of Cardiology does, not only in our programming, but in our educational activities, in our policies, our directives, that we continue to have health equity as a core principle in all the things that we do. And that we thought that if we did all those things, and we did that and we modeled that correctly, that we could reduce disparities in healthcare, particularly as it relates to cardiovascular medicine. And if we model ourselves in the right way, that other societies and other aspects of our society would embrace health equity as a real goal. And so it's been a real task for us. We first had to define, what does health equity mean as it relates to cardiovascular medicine? How do we engage our membership? How do we model ourselves so that other medical societies realize that we're serious about this and that we're going to place this as a priority for the American College of Cardiology? And then how do we embrace this in such a way that other parts of the world, that this becomes a global initiative, that we're able to teach others how to develop strategies that help us to achieve health equity. I think that we have well on our way to doing that. We are anticipating that many of our activities will result in a decrease in disparities in healthcare as it relates particularly to cardiovascular medicine. We've been thinking about disparities in cardiovascular medicine, and then we realize that based on your ethnicity, your race, your gender, your socioeconomic status, that there are disparities in care that exist in our society and globally. We've been thinking about this and talking about this really since the 1980s. And there was quite a bit of debate about whether this was real data, was it just anecdotal, or was it real? And I think that the 2002 report entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare that was produced by the Institute of Medicine really helped to solidify the data that proves that ethnic minorities and marginalized communities do receive a different level of care that results in disparate outcomes, particularly as it relates to cardiovascular medicine. And so this report helped us to both gather the data and then prove from a scientific standpoint that these disparities do exist. And I think that that has been the major initiative of the task force of the American College of Cardiology on health equity, is that how do we take this data, how do we synthesize this data, and how do we make this actionable, impactful mechanisms for change. And that's really what the task force is all about now. And as we do this, we would encourage others of our colleagues around the globe to embrace these principles and these actions to help us to achieve health equity. I think that in the United States, this has been well defined. We know that there is a tremendous legacy that has allowed this to exist. One of the things that we recognized early on, and we had a lot of debate about this, and we have thought very carefully and thoroughly about this, and that is the legacy that structural racism plays in our country contributes significantly to these disparate outcomes. And we realize that in order for us to really be successful, that we're going to have to dismantle a lot of the policies, embedded structural policies, embedded institutions that allow these inequities to continue to exist have to be dismantled. We have to first recognize it, acknowledge it, and then come up with strategies to dismantle it. I really want to use a cartoon to help people understand what health equity really means. And if you look at the first panel on the cartoon, that's what we would call equal. So you notice that everybody has the same little box that they're standing on to try to see that baseball game. But the reality is that everyone has a different starting point, and everyone needs a different level of support in order to overcome that barrier that exists in order for them to enjoy the baseball game. And so we would call that equal, and we realize that's inadequate. And then when you talk about equity, you see that on the second panel, that everybody can see the baseball game because they have the support that's necessary to maintain the height to see over the barrier, over the wall. And so that will be what we would call equity. Our true goal, though, is really to achieve justice. And in order for us to allow for health equity to result in a just and fair society, then we need to remove the barrier. And then it becomes much easier for everybody to enjoy the game. And as we talk about health equity, and as we talk about what our true goals are, we want everybody to be able to achieve their best cardiovascular health, irrespective of the barriers that are in their way. And we want to dismantle all of those barriers that prevent people from achieving their best cardiovascular outcome. And so removing those barriers, embedding strategies, embedding policies that allow people to live their best lives. And that's really what achieving true social justice is all about. Our task force believes that it is a human right to be able to achieve your best outcome as it relates to health. But there's also a business case that can be made that justifies health equity. And the Institute of Healthcare Improvement has demonstrated that between 80 and 90 billion dollars a year is what health inequities cost the United States. And this is true across the globe, that if you look at any country where there is health disparities, there's lost productivity, there's lost income, there's lost in the way of lives because of health inequities. And if we were able to resolve health inequities, then that would save us money. And the estimates are between $130 and $150 billion a year in the United States alone would be cost savings. And so this is more than just a moral plea or an ethical plea. There is a financial argument that is quite robust that speaks to the fact that this is costing the healthcare budget both in the United States and worldwide. And if we do away with these inadequacies and inequities, that we actually can save money.
In the past, when we have had conversations about healthcare and containing healthcare costs, we've always talked about cutting costs rather than investing in health. And I believe that this is a prime time for us as a global community to think about health as an investment and healthcare as an investment, rather than saying we're going to improve economy by cutting cost. How about if we refocus our interest and think about health as an investment rather than just a cost? The American College of Cardiology launched a health equity task force 3 years ago, specifically to address this issue of health equity. Coming out of that work was this concept that I wrote in a leadership page called the quintuple aim. In 2007, healthcare organizations across the United States rallied behind the concept of a triple aim that looked at better outcomes, lower cost, as well as improved patient experience. But in 2014, what we realized is that we weren't able to achieve the triple aim, even though the components of the triple aim were really worthy. But we didn't do it because we forgot to add the clinician. And so in 2014, that concept evolved to the quadruple aim, and it added clinician wellness as well as those other three components. Well, I believe that in 2021, we had evolved to the quintuple aim, so that we took the quadruple aim but added health equity as part of it. And there were two benefits from that: better health and economic benefits also. So when you think about the quintuple aim, it leads to improved economy and it leads to improved health. In rethinking the approach to healthcare, I think we have to really focus our attention on achieving that quintuple aim. And there are 4 components. To achieve the social benefits, we really need to identify those social determinants of health. We need to target prevention across disease states. For the economic benefits, we need to remove that implicit bias or structural barriers that lead to the quintuple aim. And then lastly, harness digital technology. You may ask, well, what has prevented global health equity? Why have we not achieved that goal? Well, I would say that there are fundamentally 3 issues that have really come to the forefront when we talk about this. One is there has been a narrow emphasis on health. There has been more of an emphasis on how to deal with disease, particularly infectious diseases. But now really think about health as something that we need to go after. And then the second piece is, why is there inequitable distribution of health? Why are there some groups that have better health than other groups? And then if there is that, if there's inequitable distribution, what is the root cause for that inequitable distribution? And I think looking at those 3 components and really understanding it is a starting of us trying to find a solution for global health equity. The various social determinants of health, the economic stability, the neighborhoods that we live in, the educational access and quality, our healthcare access and quality, and certainly our community support, all of that, the community context, all of that leads to chronic psychosocial and environmental stressors, whether it's because of a low socioeconomic state, whether it's because of an unsafe housing, or if it's because of food insecurity. All of these then lead to that pathway of chronic inflammation. And it is the chronic inflammation that leads to the various physiologic changes that ultimately cause cardiovascular disease development as well as progression.
And so as we look at how do we attack this, how do we achieve health equity, our task force said, okay, we realize what the goal is. We understand what the definitions are. We have strategies that we're trying to develop, but what are the targets? And how do we implement the change that's necessary? So one of the things that we have learned is that giving you the right pill, or writing you the right prescription, or doing the right procedure is not enough. What we realize is that 80% of your outcome will be dependent upon the social determinants of health that have a far greater impact on how well you're going to do. An example of that is transportation. If you can't get to your provider, irrespective of the treatment, your outcome's going to be compromised. Food insecurity. If you live in an area where there is poor access to healthy foods, all the pills in the world are not going to make a difference. Housing instability. The stress that comes with unstable, homeless, housing insecurity, those are things that undermine good health, and that's going to contribute to a bad outcome. And then social isolation. Living in a community where you're fearful, a community that is riddled with violence, that lacks adequate recreational facilities. All of those things contribute negatively to your outcome. And if we're going to really achieve health equity, then we have to address those social determinants of health because they are much more important than necessarily the pills that we give. But your built environment, where you live, where you work, where you play, where you worship, all of those things contribute to your outcome. And so we have a pretty large chore in front of us if we're going to dismantle those inequities that exist in our society. And that's part of our goal, is to help to identify those things and then help our colleagues identify those social determinants of health that are going to be necessary in order for people to achieve their best cardiovascular outcome. We have to have policies in place that help people to achieve health equity by having access to good foods, access to recreational facilities, access to good education, access to a better economic status, access to their government, having a voice, being able to encourage legislation and regulation that dismantles barriers to health equity, but embed health equity principles that allow people to live in a safe neighborhood where they have recreational activities and an absence of violence. Those are things that we think from a policy standpoint really need to be instituted from a socioeconomic and political standpoint. The other thing is purely from a social standpoint, and that is, how do you create a culture where health is valued, where doing things that enhance health and avoidance of things that are detrimental to your health really becomes the norm, and that is celebrated. And so that is something we have to really try to teach. And so as we are educating our young, and as we go about educating the community, we need to teach people, here are things that you need to do to enhance your lifestyle. Here are the things that are good to eat. These are things that you need to avoid. This is why exercise makes a difference. This is why adherence to your medications and getting to your providers makes a difference. These are things from the social context that we really need to be able to enhance our community and educate our community why they are valuable. And there are community interventions that need to be in place. And so part of our goal and part of the task force's goal is to partner with people who are in the community organizations that are interested in food security, that are interested in dismantling the housing inequities that we have in our country, that are interested in being sure that people have a safe environment in which to work and live and play. Those are things I think that are very important, and we want to partner with community organizations who share our values and who appreciate that we're all working towards a more just society. And that becomes extremely important. And then lastly, the lived experience. It is no mistake that people live by zip codes that are easily identified with higher cardiovascular mortality and morbidity. Where you live is a better determinant of your cardiovascular outcome than anything else. And we realize that it is a reflection of the importance of these social determinants of health, that poverty, housing instability is concentrated in certain areas of our cities, and both urban and rural. That these are things that determine how well you're going to do. And so by identifying those areas, we know that we can better resource allocation of resources to those areas to meet those needs. And it's extremely important, I think, that we develop policies and strategies to help us redirect resources so that we can dismantle those disparities that exist in our society.
So as we thought in the college about health care and about health equity, we decided that we needed to create a roadmap for achieving health equity. And we believe that we would leverage the three strengths of the college, which is advocacy, education, and science and quality. And so that is the road to health equity. And we believe that this is a model that could be applied throughout the world in terms of achieving health equity. Because at the corner, we do need to think about what are educational efforts, what are our efforts using data and science and looking at quality metrics, and then lastly, what is it that we need to advocate for ultimately to have that road to health equity. So paving the road to health equity is going to be a multi-pronged approach.
Let's give people the tools that they need to make a difference. And I think we can do that by one, identifying research interventions that address and eliminate health inequities. We spend a lot of money on research. I think that we need to value research on health equity. I think that that's something that, from a scientific standpoint, would pay great dividends. We should research and identify and showcase best practices. You know, we don't have to keep reinventing the wheel. If someone figures out how do you dismantle food insecurity, how do you dismantle housing insecurity, we can replicate those best practices and share them with each other and develop those implementation tools. And then we need quality measures. You know, the quality really makes a difference, you know, and we really think that part of those social determinants of health has to do with your access to quality health care and your ability to receive quality health care really helps to determine your outcome. And then how do you disseminate those best practices, the best science, the best quality metrics? That's what the American College of Cardiology does. And that's part of our goal, is to disseminate this information, help people to be empowered to make a difference, both at a personal level, at a policy level, and then for the general population. I think that if we can achieve those goals, then we really have made a difference.
As you go through this health equity lessons, you will find that one of the modules is specifically targeted for the international perspective about global health equity. And our goal with that really is to discuss the scope of global health equity. We wanted to talk about potential solutions of what we can do. What is the role of health, discuss sort of what is the role of health systems. We really wanted to think about, does the digital transformation of health using innovative technologies, can we use that to scale health equity? And what are some novel patient engagement tools? Are there certain frugal innovations that we can use? Community partnerships? What are organizations we need to partner with? What are some advocacy efforts? And lastly, what are some of the areas of research that are still needed in this area to move this topic along? So moving forward, I think we can learn from each other about best practices. I also think that we need to remember that health disparities include a broad area in terms of differences in education, socioeconomic status, healthy physical environment, and we need to just think about each of those pieces to come up with the solution in the long run.
So, looking to the future. And the future really will likely revolve around digital transformation. Our ability to technologically communicate with people, if we're not careful, can widen disparities based on your access to the internet, but it can also be a very powerful tool for change. And so we want to enable populations. We want to have health and well-being as a focus. We want to collect data that's meaningful and impactful, and we can do that with digital transformation. Public policy can be changed when we have the data in hand. It becomes a very powerful tool for change. It helps to inform legislators and regulators about best practices. How do we protect people in real time? Digital transformation can really make and be a very powerful tool for making our world a better place. And it also can be a very powerful tool for identifying those social determinants of health. As we interact with the population, being able to capture those social determinants so that we can better resource allocations that meet those needs will help us in terms of that digital transformation and allowing us to better target certain aspects of care. And then value-based care, and that speaks to quality. Changing the reimbursement and the financing of health care such that quality makes a difference and that you're rewarded for providing quality care. We want to incentivize people to provide good quality care, not just check a box, but to be sure that we're doing everything we can and that we advocate for health care and not sick care. That prevention really is the answer. That if we can provide people with tools where they can prevent disease and we partner with them for disease prevention, then that makes it all worthwhile. And then social programs and new care delivery models really have to be enabled. And I think that the digital transformation will really help to guide us there and allow us to change the way we deliver medicine and to change the way we care for people. And that all of those things that I've mentioned really should be centered by patients, that everything we do should keep the patient as the center of our efforts, and they are our highest priority. As we go about the work of the task force, one of the ways that we have started to look at this and look at the portfolio of elements that we have in order to achieve health equity, that we increase diversity, that we sensitize people to inclusion, and so by doing, we achieve health equity and social justice. And so we're trying to create a toolbox for ourselves that would allow us to achieve those goals. One of the things that we have talked about is projects that help us to analyze data, projects that help us to improve the workforce, not only in terms of the numbers of caregivers that are recruited, but also improving the diversity of the workforce. And we understand that providers who have cultural competency really provide a higher quality of care for those that share their ethnicity or racial orientations. We know that one of the things that we do well is educate physicians. The American College of Cardiology is well known for its educational tools, but we need to have those tools in a way that is seen through a health equity lens, that it's important that as we're educating physicians, that they understand the importance of health equity, that they understand the importance of identifying the social determinants of health, and in so doing, they will be able to provide a higher degree of service to their patients. The other thing that we know and that we are really very interested in is increasing our research initiatives, that the clinical trial researchers really need to be more diverse. We need to study more diverse populations of people so that the products that we provide to care for people actually works for all of our society and not just for small demographics. And then we want to really collaborate with other medical societies, other community organizations around the globe to embrace these initiatives, and then we want to provide them with best practices and tools that are necessary to really make a difference and reduce health disparities in all parts of the world. And then finally, none of this happens to a meaningful degree without advocacy. We know that one of the most powerful change agents in our country and in the world is government. That government has the opportunity and the ability to change things in a very meaningful way. And so part of our initiatives really have to be focused on educating our legislators and our regulators about the importance of health equity to help them understand that health equity should really be part of our focus if we're going to be able to achieve social justice in our societies across the globe. And so that becomes a very, very important aspect of all of the work that we're doing as a task force. And it is certainly my pleasure to chair the task force for the American College of Cardiology.
So in closing, I want to say that the COVID pandemic, again, has really highlighted health and how much health matters. And I think there's really a call to action for all of us for health equity. And I think we have to remember Leonardo da Vinci's words that knowing is not enough. We must do, we must act. And I think we need to really take this opportunity to act.
I want to end with this is a Mike Lukovich cartoon. He's an Atlanta cartoonist. One of my favorite slides. And this cartoon talks about this tree that has a few bad apples. And the reality is that many of the inadequacies that we see in our healthcare delivery system and many of the injustices that exist in our society is rooted in the legacy of structural and systemic racism. I think it's something that we have to acknowledge as a people. I think it's something that we have to be emboldened to address. I think it is something that we have to understand the undergirdings of why we keep seeing disparate outcomes as it relates to cardiovascular medicine. And that's something we have to try to dismantle if we're going to achieve a more robust, fair, just society. That this is really what health equity is all about, and dismantling structural racism and systemic institutional policies and procedures that allow inequities to exist is extremely important. And I think armed with that knowledge, then we'll be able to achieve what we're really after, and that's a true, just society.